Thank you, Henry. I have come up from New Orleans to specifically address the relationship between hypertension and racial ethnic minorities and talk about resistant hypertension. So we've heard a lot of numbers. The number that you really should focus on in the United States, 72 million, as much as 80 million people have hypertension, very common. And on the right-hand side of the slide, you see something called resistant hypertension. Resistant hypertension means that the person still has a blood pressure of 140/90 and above, despite being 3 or more medications, one of which is a diuretic. So those are patients who are going to the provider, taking medicines, and still do not have adequate control. Now, how common is resistant hypertension? People who are going to their provider, taking medicines, and don't have control. In the general practice, the estimates vary from 10 to 30%. I think 30% is high. It's probably more around 10%. In a nephrology clinic, the first bullet at the right, you're seeing people who have kidney disease. They are more difficult to control, so it may be as much as 50%. The second bullet is NHANES. I think most of the audience knows who NHANES. It's the National Health and Nutrition Examination Survey. It's the way that we get data. They survey across the United States and then extrapolate it to the entire population. In NHANES, it may be as much as 1 out of 11 US adults. And the final bullet, as the population becomes older, physical inactivity, obesity, we can expect resistant hypertension to persist and perhaps even increase. So we're focusing on hypertension in general, but then there's a subset of people who have resistant hypertension. Now, what causes a person to have resistant hypertension? Going to a provider, taking medication, and the blood pressure still greater than 140/90. There are lots of causes. At the top, there's something that's often called secondary hypertension. In the JNCA committees in which I sat with Henry, we also use the term identifiable, meaning there's something that you can identify or find that if you correct or remove, the blood pressure gets better. Drug-induced hypertension is a problem. People who use stimulants, amphetamines, cocaine, or even over-the-counter medications may have an increase in blood pressure. Volume overload, and we're going to hear a lot about volume overload in the trial, which you're going to hear about later, and I'm one of the principal investigators of. We include not only this new agent that blocks the conversion of angiotensin II to angiotensin III, but we also consider that some of these patients still may need a low-dose diuretic because volume, sodium retention is a large component of resistant hypertension. Aldosterone, which is blocked by the renin-angiotensin system, associated conditions, obesity, alcohol intake, sleep apnea. Clinical inertia means that the physician, the nurse practitioner, the physician assistant checks the blood pressure, it's high, doesn't do anything, and that's another problem. And suboptimal antihypertensive combinations. Sometimes the medicines are not mixed and matched appropriately, and hopefully this new agent that we're working on will be an addition to our armamentarium. Across the top, Henry has addressed these in detail, but these are some cartoons, are the various complications of hypertension. One of the reasons this condition is so important is not just because it's very common, I think we've made that point, but because it affects so many organs in the body, starting with the brain. When you tell patients, Mrs. Brown, your blood pressure is 160/100, you're going to die if you don't control it, the patient will often say, well, you have to die from something. So it's important for them to understand that it's not just death, but it's the disability associated, for instance, with stroke. Retinopathy, blindness can be related to hypertension. Peripheral arterial disease, leading to amputations. The picture of the heart, LVH is left ventricular hypertrophy. The heart can thicken and enlarge, which itself is a risk, along with coronary heart disease and heart failure. And the picture of the kidney is very important from an economic point of view. Along with diabetes, hypertension is the leading cause of end-stage renal disease, kidney failure. Now, why is that important? Don't see a lot of African Americans in the audience. But in the Medicare population, because you pay for persons who are on dialysis because they become disabled at a tune of $95,000 to $120,000 per year, in the African American community, it's 3 to 5 times that which we predicted just based on the population percentage. So we're paying huge amounts of sums for patients who become disabled from conditions which can be preventable. The first bullet at the bottom notes the linear relationship between blood pressure and these conditions. Every 20/10 in the blood pressure doubles the risk. So it's not a numbers game, it's trying to control the risk. The next speaks to the systolic hypertension, which is the upper number for those of you who are not clinicians. And in fact, in middle age and older persons, it's more important to target the systolic blood pressure than the diastolic blood pressure. And the last bullet has been made time and time again, the strong relationship between stroke, heart attacks, heart failure with hypertension. Henry showed this slide. I'm going to show it again because it's one of the reasons in our trial, which I'm proud to say we named New Hope, because hopefully we have something new to offer. It addresses the disparate rates of hypertension in African Americans, which is the tall bar in the middle, and the poor control rates seen in racial and ethnic minorities. In the United States, when we often talk about in our political debates that America has the most expensive healthcare system, but only the 16th level of longevity in developed societies and how poor our healthcare is, it's not true. It's not true. If you have means, if you have insurance, if you have an identifiable source of primary care, appropriate referral to specialists, the people in this room can do as well as people in Western Europe and Japan. The reason America's healthcare system does so poorly is related to some of these disparities. For instance, in the control of blood pressure seen in minorities on the left-hand side, where self-defined non-Hispanic Asians, non-Hispanic blacks, and Hispanics have lower levels of blood pressure control. So one of the reasons we're targeting this population is that the pathophysiology predicts potential benefit. The other reason is this is a population that has real need. Why do African Americans have more hypertension? We really don't know. It's a kind of hodgepodge. Those of you who know New Orleans, we have a food called gumbo. It's a little bit of this and a little bit of that, some shrimp, some oysters, some okra. It's a hodgepodge of different factors. Obesity clearly is a factor, high salt sensitivity, low levels of plasma renin, and meaning that these patients typically don't respond as well to renin blockers or ACE inhibitors or angiotensin receptor blockers, and I'll show you some data to support that. Sympathetic overreactivity, a lower nocturnal fall in blood pressure. Nocturnal comes from the Latin nox noctus, means night. These patients tend to have blood pressure that maintains itself at night. Hence, we're going to do 24-hour ambulatory blood pressure measurements as one of the endpoints to see how the blood pressure does throughout the day, not just in one visit in the clinic. Comorbid conditions such as diabetes, inactivity, and physical activity. Here's the downward slide that we've seen in cardiovascular disease. Henry showed this slide, but as Paul Harvey used to say, the rest of the story, if you look at the gap, non-Hispanic blacks have higher rates. So that gap pulls up the median such that, again, politicians talk about how poorly we're doing in the United States. Well, it depends on where you live and what's your income, what's your access to health care, your health belief systems. Here's the end-stage renal disease data. These are not my data, these are your data. They're publicly available. Black or African American is at the top. Look at the gap. It's not subtle. We don't need a biostatistician to give us an analysis of these data. The rates of end-stage renal disease in the African-American population are 3 to 5 times that predicted by the percentage of the population. Now, which drug to use? In general, the data seems to indicate that patients of African descent, probably related to volume, salt sensitivity, low renin status, respond better to low-dose diuretics and calcium channel blockers, which tend to be robust even in patients who are salt sensitive. So in the triangle, on the left-hand side, we see in the black population a better response to diuretics and calcium antagonists. On the right-hand side, we see agents which are excellent, ACE inhibitors and angiotensin receptor blockers. And the point is not being made that these are bad drugs. But what has been found when you do an analysis across multiple clinical trials, diuretics and calcium blockers in terms of the white-black difference have a better response as first-step agents. Now, if you mix and match the diuretics and the various agents, you can get similar blood pressure control. But as first-step agents, at the top, the diuretics and the calcium blockers have a greater response. The beta blockers and the ACE inhibitors, which are conventional blockers of the renin-angiotensin system, not as well. This analysis actually was done, if you look at the bottom in the left-hand corner, right-hand corner, L.M. Brewster is Lizzie Brewster. She's a colleague and friend of mine. She's Dutch. She lives in the Netherlands. So why is a lady in the Netherlands doing this analysis? Is because she looked at data across the African diaspora. And the Dutch have people of African descent in Curacao, Aruba, Suriname. The data seems to be fairly consistent that low renin, volume-dependent hypertension has less of a response to beta blockers and ACE inhibitors in this population. The ALLHAT trial, I was on the Data and Safety Monitoring Board for this trial, was an NHLBI trial, which is an arm of the NIH. 42,000 patients, 35% self-described Black or African Americans. Henry makes the point they even wanted 50%. So if Blacks or African Americans only 10 to 12% of the population, why would you want such a large number? Because you want to show in a high-risk population that a particular therapy works. And the way you do that is you overrepresent or oversample that population. And that's the approach we're taking in the New Hope trial, using the aminopeptidase inhibitor to block angiotensin II convergence to angiotensin III in the brain. We would like to oversample for racial and ethnic minorities. And it's not social science. We're not just doing it to be, quote, politically correct, end of quote. It's because the pathophysiology, the observational data drives us to target that population. In ALLHAT, if you go to the bottom bullets, the ACE inhibitor and chlorothalidone in the non-Black patients, predominantly Caucasian, had a similar effect. But in the Black subpopulation, which was substantial and overrepresented, chlorothalidone, the diuretic, was more effective. Amlodipine and chlorothalidone had similar effects. Another problem that we're going to look for in our trial, we may not find it because it's relatively uncommon, is angioedema, marked swelling of the tongue, the lips, and the eyes, which for some reason appears to be more common in Blacks or African Americans. These are data from the ALLHAT. I'm not going to go through all the numbers, but basically what it says, if you look at the bottom, the p-value is statistically higher for the relationship with lisinopril versus chlorothalidone for angioedema. The ALLHAT authors suggested in their landmark study that ACE inhibitors therefore should be considered second-line therapy. We're going to invert that finding and study whether or not the new agent, the aminopeptidase 8 inhibitor, blocking angiotensin II and angiotensin III, that it's been shown in bench research using animals, may be more effective in patients who have low renin type of hypertension. That parentheses JNCA, you've heard about JNCA, and Henry said it, and many of you did not get it, there is no JNCA. JNC stands for Joint National Committee of the National High Blood Pressure Education Program, which was sponsored by the National Heart, Lung, and Blood Institute of the NIH. It's a mouthful, meaning that this was an official study of the United States, but the committee was disbanded, and the authors who were originally appointed to the committee said, what the heck, we're going to go on and publish our paper anyway. So that being said, there is no JNCA, but the authors suggested, looking in the middle in terms of black patients, that you should initiate with a thiazide diuretic or a calcium channel blocker in this population. What we're attempting to study is a new class of agents to see if it becomes as effective in that population. So in conclusion, I think if you look at the data in general, if you read not only my research, but just read general textbooks on hypertension, cardiovascular disease, then you will be sensitive to the fact that hypertension control is poor across a wide range of patients, but especially racial ethnic minorities, and specifically in African Americans, with high rates of CVD, cardiovascular disease, and CKD, chronic kidney disease. The second bullet is that effective pharmacotherapy is still, for many patients, out of reach. We do know that low-dose diuretics, calcium blockers, appear to be more efficacious as a first step in these patients. And hopefully in the future, we may develop a new class of agents which also adds to our approach to controlling blood pressure. Last 3 points: vigilance and innovation, not only in medications, but how we treat patients, how we assess patients, and universal health care. Uninsured patients do poorly, and uninsured patients are more common among racial ethnic minorities. Second bullet, the recent decline in cardiovascular disease, if you look at those curves closely, is starting to slow down. It's plateauing. So we need to ensure that patients have access to medications, that the newer therapies that are developed are applied equally to all populations. Third bullet, hypertension is a major risk factor for cardiovascular disease. And if you have hypertension, regardless of how you feel, this is not a feel-good story or a feel-bad story. It's a risk for cardiovascular disease and end-stage renal disease, and hopefully we will have exciting new therapies that can approach these problems. Our general goal across the society here in the United States is to have what's called health equity, where you see we're reaching for the apple, and that we find ways of helping those persons who are falling short have equal outcomes to the general population. Thank you very much.